I can't see very well. There's only two I have up there.
It looks that way.
Yeah, okay. So why don't we start down there in the corner?
I'm Amy Snyder. I supervise the Healthy Schools program, which is in the public health service area and prevention and health promotion.
Dana, everybody knows Dana for the most part, I think.
Shannon Bristol-Ragas, Deschutes County Behavioral Health Program Manager, Comprehensive Care.
Evan Namkun, Program Manager with Deschutes County Behavioral Health of the Forensic and Acute Services Program.
Amber Clegg, a Clinical Program Manager for Behavioral Health, and I oversee the Access team and a lot of integrated care projects.
Peter Moe, retired pediatrician.
I'm Jessica Jacks, Program Manager in Public Health over our Prevention and Health Promotion section.
I'm Julie McFarland. I'm a NAMI board member, and then I also have a family member who's utilized Deschutes County Behavioral Health Services.
Paul Partridge, I'm the program manager for the Deschutes County Intellectual Developmental Disability Services.
Danielle McBain, I have a kiddo that accesses services through Paul's program as well as previously in the mental health program. I also happen to work at Mosaic.
Michael Schultz, so captain with the Deschutes County Sheriff's Office. I operate the corrections and court security. And
Tony DeMone, Deschutes County Commissioner. Saturday I missed last month. Right before that, we did rotate the assignments of commissioners, so I missed February, but I'm here in March now. Great to see everybody.
Glad to have you, and I'm Melinda Thomas, Chair, and I'm an attorney with the High Desert Education Service District, and I do a lot of work with special education representing school districts. Okay, Lee, do you want to take the next item on the agenda? I think we need to go fairly quickly on that, but the feedback from BHAB to the County Commission? Lee? You're up, Lee. Can you hear us?
Sorry, computer's being weird today. I couldn't
no
get
worries.
the mic to work. So if anybody has any general positive or constructive feedback for the county, this would be the chance to offer that, either just a generalized positive or constructive piece. So and this is for all members or community individuals present. So we're sharing feedback.
Anybody have anything?
Does it have to be specifically for Deschutes County Behavioral Health?
No. I mean,
Okay. I went and visited the new lighthouse, Shepherd's Ministries, and I got a tour, and they were amazing and super professional. And so very quickly, it's 100 beds, men and women. They are opening their own kitchen. They will serve breakfast, lunch, and dinner. And it's a pretty, organized operation. They opened in November. So it was nice to see a new resource in Bend. I was impressed with their professionalism.
And Melinda, this was just, I didn't quite hear Lee, like kind of the general comments about
how things are going, behavioral health, the county, the area, things that we would want to let Commissioner DeBone know about, and any feedback, any constructive suggestions. Linda, I see your hand up.
Yes, and I don't see a raised hand on my screen, so that's why I did that. I have some general feedback of the last 30 to 60 days from the adult foster home perspective, and it has to do with as leadership changes at DHS at the state level, specifically in the adult foster home area, which is where I live, how the tone and the mood and the feeling of the working relationships change. And it's pretty palpable right now without getting into great details. And I guess my feedback is for those of us at the bottom, right, not at the bottom, but face to face living in the experience with the people who come to us for help and places to live, it changes our climate and our tone and our feeling about our work significantly, more than I ever realized it would. It's the same resident, it's the same people at the county that we've known and respected and team worked with for us for 13 years. But the way things are being interpreted and managed has shifted significantly. And without getting into details, because we don't have but a few minutes here, I want to say that it's not fun anymore because of that. And it's making it harder to feel good about our jobs. And I don't mean that to sound touchy-feely, but it does matter. And in other worlds, when we look at employee retention and employee satisfaction and turnover, and can we get good people, while it may not show up immediately, in 2 or 3 months, it is going to show up long-term. And if you want to dig deeper, call me. I think that's probably enough to give the spirit of my feedback. And thank you for listening.
Thank you, Linda. Does anybody else have anything to add?
Super quick, I mean, this is not an unknown, but in the past couple months, I've personally had texts and calls from people who have kiddos in distress who need a residential facility. We all know that's some are friends, some are I know through working with my son, and they've reached out just wanting to know, where are we at? Are there beds? So that still continues to be a concern.
Anybody else?
So I chatted with some of my peers in the pediatric world and visited over at Mosaic. And they have embedded behavioral health people in all the various clinical nooks and crannies, as does for sure Central Oregon Pediatrics. And clinicians, medical clinicians, are so happy to have somebody who is, first of all, available and knowledgeable to give immediate feedback, to see people right away. And my experience when back in the 70s and 80s, when we were really all alone, it was that you could wonder if somebody had some behavioral something or another, but you knew they had the time, the expertise, or the backup to do anything about it. And the report is, the experience is exactly the opposite until kids get serious enough so that they need inpatient, and then there's not almost anything available.
I would say the one other piece is also bilingual mental health therapists as a challenge.
Oh,
I
wow.
know the county,
Yep,
we
Mosaic
have
is
at least
very
one.
helpful.
Mosaic, we've worked hard to try and get them. They're hard to find. We all know that. But I think it's that's feedback we hear at Mosaic and parent groups that I'm a part of. But I agree with exactly what you said. I think more of the day-to-day mental health challenges are a little easier to address than they used to be with embedded behavioral health with the pediatricians and of course the county wraparound services. I would say people still get confused about how to get wraparound services. That's the only other thing I hear. I know I had no idea what it was until we had a teacher who was like, I'm referring you. And so getting the word out about that is always a big thing, but yeah, agreed.
I think Lee and I have had a lot of conversations with Holly and Dana about a little bit of a longer term project for this group is to try and figure out how do we get that word out, because it is a really complex system to navigate and it's perennially an issue. So that's something that we'll be bringing to you in the coming months about how can we assist in that.
So I would add, sorry, I just took a bite. I would add that's complex to navigate. IDD has also been complex to navigate, especially for people who are first getting diagnosis, not knowing where to go. I have the doctor who evaluated my son. She calls me on a regular basis. I have a new family. They just get a diagnosis. What would you recommend? So it's just not known, and it's really hard to find those resources.
And there's so many, I mean, there are a lot of them.
They're
A
there,
lot
they
of
just, you don't
agencies,
know.
A lot of private providers, a lot of partnerships, and it's just hard to navigate that process. And so, that might be something that we look at, a community outreach type of project to assist with that as best we can. It's a complex landscape though. So just so you know that we have been talking about that as like a longer term project for this group. So, okay. So we are,
Couple just
Oh,
roundtable
yes.
items that we may come across these So Dr. Bohm, good to see you. About 20 years ago, you said hi to my little kiddo. He was just a wellness check back in the day. So my wife always remembers. And I'll say, oh, I saw Dr. Bohm today. She remembers that. He's 26 now, married and working and doing real well. So it's just fun to see you so many years later. Real positive. Wednesday, we did purchase an IDD home in Redmond. So on our consent agenda was purchasing. That was IDD plus mental health and complicated issues. And Paul could talk a little bit about that. And it may come up. So I did tour the Redmond Shepherd's house just this last week, in fact. So remember, we've got another whole facility up there. Day operations, people can check in for night operations, very stable environment for the people that are taking advantage of that. And we also, maybe, I don't know, since your last meeting, we are celebrating serving 100 people or 1,000 people at IDD also. That was a press release and some of the great work we're able to do, expanding that capacity. And one of our high level issues, high priority items is treatment facility for juvenile in the Redmond area. So Capital's coming together for that. We're advocating for that. And that would be, it sounds like resolving some of the, what do we do now when something gets really complicated? So that's a priority. It's always tricky coming up with money, finding a place, getting the operator, putting the big picture together, but we're working towards that.
Thank you. So we have a presentation at Healthy Schools.
I said I have to get this started, but it's different. So first, we share screen. That is not where we want to start. There we go. All right. Hello, everybody. I'm Amy Snyder. I supervise the adolescent and school health programs for Deschutes County Prevention and Health Promotion. I'm starting a timer for myself because I used to be a lecturer at Oregon State University and I could talk for a very long time. So I'm here to present to you about Healthy Schools outcomes from embedding our local public health staff into the K through 12 schools. And this is coming out from the public health service area from Prevention Health Promotion. I have Jessica Jacks, my manager, with me too if we have any questions about administrative things. I presented our annual report for Healthy Schools to the Public Health Advisory Board back in November, and Cameron Fisher suggested that we present to this group, and Cameron Fisher is also invested being a Bend Pine Schools board member. So that's why, one of the reasons why it spurred us to come to this advisory group. So the objectives for what I aim to achieve with this presentation is for, by the end of the time I finish it, you'll be able to describe Healthy Schools and our outcomes, and you would be able to share about the benefits of Healthy Schools and connect us to any additional resources or opportunities that may come about, including of like, I think it would be good for you to share this information with this group or that group. So we want to make sure that we're getting our information out. And then the last objective is to describe differences in behavioral health provider rates across Deschutes County zip codes. That's not about Healthy Schools, but it is something that we uncovered while doing our work in Healthy Schools. And we thought this would be an appropriate place to bring this information because it's beyond our sphere of influence from within the schools. Yes.
This view doesn't allow for the people on the screen can't see you switch screens or slides. So if you exit out of this. Yeah, that's perfect.
Oh, show it like this.
Great, but the people on the screen, when you switch slides, they can't see it, but it's just you.
Okay. So just go through slides like this.
Unfortunately.
Is there another way we can do it? I have a lot of information that won't be shared. Let's try another share screen option. Where did Teams go? Is it online? Oh, yeah, online. Let's share the entire screen and maybe that will work. Can we see now? Let's change screens. Yes, that's perfect. Perfect. All right. So just take a moment.
Wow. Holy smokes. You're going on my speed dial.
take a minute, is knowing that we're, a lot of us are here are often talking about behavioral health or other types of clinical services. So just take a moment and imagine yourself inside of a school building. And we, Healthy Schools is implemented in middle and high school. So imagine yourself just kind of inside of a school and visualizing the entire school population. And that's about 400 for an average large middle school, about 411 to 14-year-olds, and all the great things puberty provides us. And then about 1,200 14 to 18-year-olds. And I like to just imagine them in that kind of fast forward view, like 2 times speed, just kind of zooming in the building, going between classes, going between social groups and interactions, and different kinds of exposures that they have through those days that can affect their mental behavioral health through their journeys in the school system. For us in public health, this population setting is a really great place to do prevention and health promotion work. We're taking prevention and health promotion to them where they spend the majority of their waking hours. And so as I talk about Healthy Schools, just try to remember that whole population. One way that we translate the work we do to a clinical model is to share that our patient isn't an individual, but it's that whole population. So all 400 of those students, all 1,200 of those students, depending on what building we're in. The way we assess and diagnose health problems is using population health statistics to predict, to look at where things are affecting groups of students more, and then targeting our work to address populations or groups. Our prescribed treatments are at the organizational level for Healthy Schools. So our interventions or treatments that we're delivering are policy, systems, environment changes. For me, I'm aiming for district-wide changes, school-wide practice changes. And then the unique thing about us is that those who are delivering the treatment isn't us ourselves. We might prescribe it as this would be the recommended practice, but it's school administrators, it's school staff, it's student leaders, it's families, it's our partnering organizations that are delivering that treatment in a coordinated effort so that students are wrapped around by this health supporting, health promoting environment. So what is Healthy Schools? We're a formal cost-sharing partnership between Ben Lapine Schools and Deschutes County to embed our local Deschutes County public health staff into the school system. We provide our essential public health services. So we engage, we assess, we educate and inform, we plan, we build capacity and systems, we support implementation, and we do evaluation, reporting, iterations. So it's that collaborative improvement process that we run. And then we do this in order to prevent youth behavioral health issues from ever starting. So we're in that preclinical stage before it becomes clinical symptoms that would then take someone to a healthcare setting. We are aiming to do primary prevention, so before symptoms ever start, before exposures start, to reduce susceptibility. And then we're doing early intervention, so before there's symptoms, identifying risk, identifying cases that may become clinical and getting them into treatments based on screenings and referrals. So this is our team, but this is also the design of our program. I am on the top right-hand corner. I serve as the district's prevention and health promotion strategist, and I coordinate efforts across the district level in all the different service or program areas that a district has. And then the 5 other staff are our school-based public health specialists, or if you can think of them as school-based prevention and health promotion specialists. And each of those little icons is the school that they belong to. So Amanda there on the top left-hand corner, she is the Lapine public health specialist. She works full-time in Lapine High, that's this icon, and in Lapine Middle School. And so she'll split her time between those 2 buildings. Everyone in the building knows if there's an issue related to public health, related to vaping, or related to concerns about youth mental health, they're going to go to Amanda to say, what should we be doing? What could we do? If she doesn't have the guidance, she knows who to go to with our different specialists to be able to resolve that issue in a coordinated effort. This graphic here represents our approach. So it's called a whole school approach, or it's called coordinated school health. But if you think of this as the entire student population in the center of this circle, and if we're working on something like suicide prevention or substance use prevention, we should have preventative interventions happening in every single one of these areas in a coordinated approach. So for suicide prevention, it's thinking of what are those resources that students need to be able to connect to, or families need to be able to connect to if someone is considering suicide, or if they need early intervention, preventative treatment support. How do they know to go to 988? How do they know how to connect to the school-based health center? What are they doing in the health class? So health education is, what are the health teachers delivering for suicide prevention education? What are the teachers delivering for substance use prevention education? For this one, positive inclusive school climate, it's that welcoming, engaging, enriching environment throughout the school. So if you think of a clinician working individually with someone to help them be able to cope with their challenges, and then we send them back into an environment that can cause harm, we want to make sure that that entire school environment is warm and inviting and built on connections, not just between one teacher or one administrator or one on-site clinician, but everyone in there. So even their engagement with their peers is positive and supportive. And then we have, what are we doing with family engagement to help families be able to navigate systems, to help families be able to do health promoting activities at home based on their interest and needs. And then we have this part over here that's slightly covered with this. I don't know if I can move that. Yeah, I can. Oh, look at that, just go away. We have our community engagement in the school health improvement process. That's that engagement, planning, building, doing. We want to make sure that all of the entities that are affected by our work are engaged as representatives in planning this work and implementing the work. So we have students involved as leaders in telling us what we should be doing. And we often take the back seat and let them take the lead in doing that work, which I'll tell about more if I have enough time left. If I messed up, okay, there we go. So to jump to the outcome, we've been implementing Healthy Schools for 3 school years now. We are on our 4th school year, and now we have longitudinal data to share as far as our outcomes, being student health outcomes that we're aiming to affect. So this is what we call our 2025 evaluation. It's our first formal outcome evaluation. Our evaluation question is, how has Healthy Schools impacted student health outcomes? Every evaluation we do will have that main question. For this 2025 evaluation, we decided to look at a specific outcome. So we're considering that a case study. How well did Healthy Schools work on preventing emergency department visits for ages 11 to 17, so that's middle and high schoolers, in zip codes with Healthy Schools compared to zip codes without Healthy Schools? There were 5 codes that we use. There's 2 codes for suicide. There's 1 code for substance use, and then there's a code for depression and a code for mental health. So we pull those visit diagnosis codes to see, are we making a difference in preventing behavioral health care ED visits? We used a quasi-experimental design. That's the highest quality of design you could do with an intervention like this, to be able to test causality. And we used a linear regression model, which is comparing the differences between 3 years of baseline to 3 years of follow-up in the treatment group, which is the zip codes with Healthy Schools, and the non-treatment group, which is the Deschutes County zip codes without Healthy Schools. And I'll show you a graph shortly that will explain that a little bit better. The results of this is that 1 in 5 emergency department visits related to these behavioral health diagnosis codes were prevented in the zip codes with Healthy Schools for ages 11 to 17 compared to the zip codes without Healthy Schools. The small text that goes along with that, just to explain this a little bit more, is that over the 2024 calendar year, so January to December, 84 visits or 21% of behavioral healthcare ED visits were prevented for this age group living in zip codes with healthy schools compared to zip codes without healthy schools. So that's North County. The actual number of visits for healthy school zip codes was 324 compared to the expected number of 408 based on the trends between the treatment and comparison group over that 6-year timeline. So to give you this, what it actually looks like in the regression model, that solid green line is zip codes with healthy schools. So that's the actual number of visits for the Deschutes or for behavioral health related ED visits. The solid blue line is the zip codes without healthy schools. And just for some reference, about 70% of Deschutes County's population lives in a zip code with healthy schools, and about 30% lives in one of the zip codes without healthy schools. So if all things were equal, it should be, we have 70% of the cases in the zip codes with healthy schools, and then the rest are in the zip codes without. This vertical line represents when healthy schools began to reach students in the Ben Lapine Schools zip codes. So that's the mark of intervention. So everything on the left-hand side is considered that 3-year baseline, and then everything on the right hand is considered the follow-up period, the 3-year follow-up. And then the dotted line that's up at the top is what was the expected number of visits over that time based on this trend line here. So if you look at these two lines between the zip codes with healthy schools and the zip codes without, it's almost parallel to each other as far as trends in ED visits. And then you see here where there's a turning point and you see the actual number of visits decrease significantly over the 2023 calendar year and the 2024 calendar year. This number 35 represents the number of visits prevented in 2023. And then this 84 here is the number of visits prevented in 2024. 2024 is where we got to statistical significance based on the effect size. And just some additional reference points, healthy schools phased into Ben Lapine schools over a 3-year period. So we began in 2 schools and then me at the district level working with health teachers in November 2022. Or 2021. And so that's where that little 2 triangle is pointing towards. And then at the beginning of the 2022-2023 school year, we expanded out to 10 schools over that school year. And then at 2023-24 school year, we were in all 14 secondary schools, middle and high schools. And then that is pointing to where we have our statistical and clinical significance of that 21% decrease. We wanted to start getting to an estimate of potential cost savings of this work. So for 2023, I have the charges data through the state database for specifically self-harm and suicide-related emergency department visits and hospitalizations for this age group for all of Deschutes County. The total amount was about $1.5 million. About 50% of that is charged to Medicaid, and 1%, which is about $15,000, was for uninsured, and I assume that that cost was assumed by the hospital providing the care. When I calculate for 2023, we made up for about 66% of those emergency department visits. I know it's different for every visit based on severity and length of stay, but just rough estimate wise, about 66% was about $1 million. And then if we used what we prevented from 2024 for that, that's about $200,000. So I'll repeat this estimate with the 2024 charges data when I get it. But that's just a loose estimate, knowing that we have other data that aren't included in this yet. So to explain a little bit about how we got there, I have just some snippets from a couple of our program areas to highlight. One of our main areas that we worked with, and it's probably the earliest area where we started seeing differences that were reaching students, was our work with health curriculum and instruction. So we've identified that we've reduced policy to practice gaps by increasing the proportion of health teachers, so all secondary teachers, covering these required topics. So these are required either by Oregon law, or for suicide prevention, it's required by a district policy. And you can see here where we did our training. So for suicide prevention and child sexual abuse prevention, these are two that we started working on early, getting assessments of what the barriers were, identifying that materials and lack of training were the biggest barriers. And so that's what we focused on that first year. And so you can see the progress that was made in those first 2 years of our work there. And then opioid prevention and response is a new legislation, now requires opioid prevention lessons in 6th, 7th, 8th, and then at least once in high school. And that started this year. And so you can see where we did our training this year in October. The first day those lessons were supposed to be live, we had our teachers convened for a full day. We brought in our subject matter experts from the county, so our opioid prevention strategists, and our substance misuse and problem gambling prevention supervisor provided a training. We had our teachers all ready to go, and we just needed the lessons, and then they were able to implement. I think we might have been the first in the state to be that ready. And then for health ed, we also work on reducing research to practice gaps. So we know there are effective interventions that have already been proven to address health behaviors that we're targeting. So we want to make sure that they're in effect. So for example, for substance use prevention, one of the programs that we use is Catch My Breath. It's proven that it reduces vaping experimentation by half for 7th graders. So we've worked with teachers to have them review it and select it, put it into the scope and sequence or their plan of instruction. We have for mental health promotion and suicide prevention, I wanted to call this one out because Ben Lapine Schools has had a policy that has required 6 evidence-based programs to be taught in health classes. At one point, I know there was work with Deschutes County Prevention and Health Promotion to make sure teachers had all those materials, but over time, there's transition, attrition, and that gets lost. And so it does take ongoing work to constantly make sure that the teachers have the tools they need and to provide new trainings to make sure they're confident in their ability to deliver a sensitive topic in their classroom. And so we improved that work as well. Sources of strength is our biggest evidence-based intervention or evidence-based program, meaning it's research tested and it's proven to work. This shows our increasing of having Ben Lapine Schools implementing a Sources of Strength peer leader program. When we started, there was a school that was already implementing Sources of Strength, and then last year through a lot of capacity building, we've got the majority of secondary schools, so that's all middle and high schools, implementing Sources of Strength. And then this year we have 15, which is all of the secondary schools plus one of the 2 K-8 schools, which we started working in one of those K-8 schools this year as part of our focus on improving services for rural areas, specifically South County for us. For Sources of Strength, one of the ways it works is by providing a link to care. We have trained almost 800 students since we started this work in fall 2023. That's about a 4 to 6 hour training to build community and to teach them about how to recognize warning signs and be a connector to help. Oops, there we go. This graphic in the middle, or the graph in the middle, shows our outcomes from just the training alone. 91% of the students who attended our trainings last year reported that they felt confident in their ability to access help when they needed it, and they felt confident in their ability to connect a friend who's struggling to help when they need it. And the reason this is important is because you look down here, Ben Lapine School students are more likely to go to a classmate or a friend for help when they're struggling, and it increases as they age. compared to going to a teacher or a school counselor, which decreases with age. So we know it's important to have this safety net and connector to help within social networks. And this is some preliminary data from our peer leader pre-post test that we're doing this year. We're doing this across the district, and this is just prelim results from Bend High School. This graph shows that the blue bars are the pre-assessment, and then the red bars are the post-assessment. This is students' actual referrals to an adult, so a self-referral to adult for help for themselves. And then this is actual increase in referrals to help a friend. So these are simple things of like, I think somebody's struggling with this kind of personal problem. So it may not be a referral for treatment, but it may just be, I need some adult guidance and mentorship in this, personal problem that I'm navigating. And then this graph shows, if you look at these 3 bars in the middle, these are students saying that they would go to school staff for help. Around the district, it's usually about 25% of students say they would go to a school staff member. After being a Sources of Strength peer leader, it goes up to greater than 50% are reporting they would go to an adult staff member at school. This bar here is parents, so going from 25% to 50% saying they would go to their parent for help. And then this one here is that saying that they would go to no one, and that reduced from 25% to less than 3%, that they had no one to go to for help at school for a problem. And just a little bit to expand that, Sources of Strength being an evidence-based program, it has 2 roles. One is as a connector to help. The other is as agents to change. And so students are working to be positive supports through their schools, and they do school-wide health promotion activities. Over the school year last year, that resulted in 35,000 dosages of positive inclusive activities throughout the school, increasing student belonging, student engagement in school, their connection to a caring adult, and help seeking. And this is just an image from a Lapine family night that was very well attended. And I am going to skip this. This is just a nod to our annual report. If you search for Deschutes County Healthy Schools and then scroll down, 2023-24 annual report has those success stories in it. The last thing on Healthy Schools is I wanted to share, these are staff ratings from last year to this year in last year's survey, reporting how well their school's doing at being a coordinated system of support. So how well is their school connecting staff to prevention resources before issues start? How well are they bringing in community resources, which include like our school-based health centers? How well are they engaging families? How well are they implementing effective programs like Sources of Strength? How well are they coordinating across teams to improve alignment? And then how well are they communicating about student health issues and initiatives? So just a conclusion to wrap this up. For these 2 objectives, and I have one last objective to get to, we prevented 21% of behavioral health related ED visits for ages 11 to 17 by embedding public health, prevention and health promotion into schools. There's a potential cost saving of $200,000 per year, though I still need to do a calculation based on the 24 data. And then we've reduced policy to practice gaps and research to practice gaps for health promotion in schools. And then we've improved coordinated systems of supports for prevention and early intervention services from within the schools. So the last thing I wanted to share was just to switch over to disparities. This is not related to our program, but it's something that we've discovered as we started looking at our results. There's differences in behavioral health care provider rates across our zip codes in our county, and I'm sure you're aware of this, but it was surprising to us. And as we're working with our school partners, they've asked us to start sharing this data with the behavioral health system. And since many of you are engaged in different organizations, we thought this would be a good place to share this. So this is full-time employment equivalents for every 10,000 people. So this is a rate, meaning that in the areas that have less than 10,000 people, their provider rate is multiplied. So it's not the actual number, but it's adjusted for population size differences. For the Bend zip codes, this is 01, 02, 03, it averages to about 20 full-time employment equivalent for every 10,000 people. For Lapine, it's 2.3 full-time equivalent for every 10,000 people. This is Sun River, 1.5 full-time equivalent for every 10,000 people. And then this is North County, Redmond and Sisters, Terrebonne, at about 10 for the larger city areas. So I wanted to share that with you. That probably could have been in that initial roundtable where we discussed topics, but didn't want to jump in yet. So any thoughts or questions?
Yeah, so going back to one of your, first of all, this is great. And I learned a ton, thank you. And I think my son signed up for Sources of Strength next year. And I didn't know that's what it was, so that's exciting. In one of your earlier slides, you were talking about how, this Healthy Schools is preventative and you're doing middle school and high school. As a parent who's had a kid who struggled with mental health early in elementary school, I'm curious about why, if it's just timing, you start it here and then add the elementary schools, because if truly it's about prevention. I mean, I don't know how many times I talked about this when my son was young, like to keep him out of Captain Schultz jail, to keep him from being homeless, to keep him from all, substance abuse. The time to get him was when he was little. So I'm just curious about that.
Yeah, there's elements that I do at the district level that reaches down to elementary. So we're starting to work on the elementary health curriculum, but we started with the secondary level. And as far as the school-based public health specialists, the recommended capacity for them is 0.5 FTE for every public health specialist. So for per school. So one public health specialist should ideally be just working in 2 schools, and we're already stretched a bit to have them in 3 schools. And that's because we have 2 main feeder schools. So the middle school that feeds into the high school and then an alternative school. We didn't want to leave the alternative schools out, so we added them into our clusters. But we do recognize that we need to start, especially with some of the prevention topics in 3rd, 4th, 5th grade. And so we're working on that, and we have built a plan of instruction to start with for those grade levels, but still need to do a little bit more to it. That's great.
Glad to hear from
I would just add that there were some things that were not efficient in the middle and high school level that we needed to address. And so, it's the hope to be K through 12, and to your point, really do need to be starting early, but needed to address many of those things that Amy described today.
One of the curses in community-based interventions is that oftentimes the cost of providing the intervention, which saves money, the provision are not the people whose money got saved. Like I suspect that emergency room visits is where that $200,000 came from. So for the community, it makes a big difference. But it doesn't motivate some organizations to provide some program or another because they don't see any improvement because of it. So Tony, this is a county and state issue where we can do better in many ways, but we don't incentivize the people who provide whatever service it is on the one hand, and we don't even think about that as an issue as often as we should.
Well, and it's been a split vote a few times, and we all know this. I mean, you and I know for funding this program, and it's been supported. And now we have a little bit of a runway and some information to be able to talk about too. So this is showing that the investment is effective.
I think, Peter, to your point, I think of that a lot when I'm writing grants at Mosaic. Oftentimes when we're talking about the work to provide healthcare to people experiencing homelessness, we're talking about savings to the ED department. We're talking about savings to the city EMS. We're talking about savings potentially maybe to the sheriff's department, not preventative. And so how do you capture that? That the funding burden goes on Mosaic or whoever, the county in this case, but the savings end up, somewhere else. And so how do we, I think that's the question, how do we make that savings kind of work for the people that are doing the work and where it's being saved? I don't know.
I would
I
say
think
this,
of that a lot.
this wouldn't be our only savings. It's the data that we had access to that was a complete data set versus if we were aiming to pull data from Mosaic and La Pine Community Health Center, like those are not the same data sets. And then it's a lot more cumbersome to try to figure out how do we and what codes do we use. So the ED data is a really nice data set that we can use. And that's why we use that one. But I think we would have to make assumptions of the other impacts that have been made, just knowing that there is a lot of space between early intervention and that crisis response. We did, when we first had our data, it came up with the question of, well, are some of those cases going to the stabilization center? And we were able to pull the stabilization center data by zip codes, and we saw the same exact pattern with the stabilization center data. We didn't do the regression model, but we have the proportions that we presented before. So there's other impacts. We're going to be looking at other data sources to see how much do we see this consistent pattern across different types of outcome measures. So that's some work to be doing. But we should actually see some more help seeking at those earlier intervention levels, which is preventing that later, more expensive crisis level.
Lee, did you have a question?
Yeah, this is great. Thank you very much. Appreciate that. Last year we had a really impassioned and somewhat difficult in content conversation with the Redmond School District on their needs and how some of the things y'all are doing could maybe overlap in helping them with the things they brought to us. But what are the two things, if there are any, and it's maybe a Jessica question, where are we at potentially going to the North County side of things and addressing that disparity, if at all possible, to supplement Mosaic at Lynch and Redmond in whatever way that they're already helping out with their school-based programs there. And then, I wanted, coming out of COVID, you guys came in COVID, you made a great effort and did really great things given all those barriers, but we still don't really know what that was, especially for younger kids and social learning and the impact of like hidden things like domestic violence that got to hide through COVID on these kids and how that then ripple effects into what we see in behaviors in schools and ED visits. And how are you guys going to help that elementary piece has been talked about, but how do you see yourselves expanding from where you started?
Yeah, I'll chime in on that. So I have been in prevention for quite some time, and this program has been the first time that I've felt like we have been able to be truly effective. And I've worked in Benton County, I've worked in Deschutes County, and so it's really, really exciting for me to see this really, I would call Healthy Schools as a vehicle for our prevention and health promotion to work, because we've had the expertise, we just have not had the coordination and the capacity to really be in the school setting and really actively partnering in this way. So Healthy Schools really did start as, let us try this out, right, to the budget committee, and we were allowed to do so, and we're did so with Ben Lapine Schools as partners. And it's my hope to be addressing and have healthy schools across Deschutes County. We do have to consider the resources and some of the things that Amy and I are doing now that we have some data behind us is really trying to petition our existing funding streams. So the historical prevention funding streams have been really, really siloed, and here's this lane for cannabis prevention. Here's this lane for youth suicide prevention. And what I am attempting to do is to braid that together. And can we loosen those a little bit up so that we can really collaborate, because a program like Healthy Schools is truly impacting the root causes and the risk and protective factors that are in all of those behavior concerns. So that's some of the work that we're doing. We have had some conversations with Redmond and Sisters School District, just because we wanted them to be aware of this information, aware of the program, but aware of the information if we're saying, we're seeing some differences in this work, and knowing that might impact them. So we've had some conversations with them. I think there is interest. I think it's just about getting the pieces in place. So anything else you'd want to add to that, or to tack on to that question?
Unless there are any other burning questions, we're about 10 minutes behind on our agenda, so I do want to keep us moving forward on there. Are there any final thoughts, any burning questions before we move on? All right, thank you, Healthy Schools. Thank you so much for coming to visit with us. It's very interesting, useful information. And so we're going to move on. We've kind of reordered our agendas and kind of restructured them slightly. We're going to always have a chair and co-chair report, just because Lee and I are working sort of behind the scenes trying to see how we can make this group a little bit more effective and move forward. But before we move forward on that, we do need to approve the February meeting minutes. So hopefully you've all had a chance to take a look at those. I think Dana sent those out by email. Does anybody have a motion? Wait a second.
Second.
Any discussion on that? All right, we'll take a vote. All those in favor say aye.
Aye.
Any opposed? Any abstained?
Oh, see, I wasn't here.
Yeah. All right, it passes. Okay, so they are approved. One new item this year that I had not heard that we had done before. I don't know, perhaps Dana has the history here, but the county undergoes an audit, and I think is it a behavioral health audit, or is it a larger? Okay, yeah, and so they undergo an audit, like most public bodies do every year, just to make sure that we're doing the right things and following the laws. So it's not just financial, it's a lot of different things. And so the auditor this time pointed out a couple of corrective actions, I would say, one of which is that our board has to, by law or by regulation, have at least 51% of our members who have lived experience with behavioral health. So that's kind of a new thing that we're going to have to sort of make sure that when we think about onboarding new members and recruiting new members and maintaining our current membership, we've got to meet that threshold. And so Lee and I talked about this. Lee met with Holly and Dana about this. And so the question is, what does lived experience mean? How do we define it? And so what we settled on was that a board member has either personally experienced behavioral health challenges, or has a close family or household member that has experienced behavioral health challenges, such that it has had a significant impact on the board member's life. So that's kind of our definition that we've adopted for this. And so we don't need to get that number right now. The point is that I want to let you know that we are going to be sending out an annual survey. So expect that to come, and we will ask you to self-declare yes or no. We're not asking you to provide details of what your lived experience is. Of course, we would like to hear it if you are so inclined to share, but that's not the intent of this. We just need to do this kind of an anonymous survey, just a yes, no kind of thing, just to make sure that we're monitoring the composition of our membership. Any questions about that? Okay. And then Lee, you're going to talk about the drug use tracking or the delegation?
Well, that came up as a secondary finding for us to potentially look at, and according to the OARs, that is a thing that each county needs to be delegating and tracking and monitoring. And it's also through our conversations, is that a thing we do? Is that a thing public health does? And I think from conversations with Holly, potentially tabling this for later, or considering, because we can delegate to someone, and I'm not entirely sure, Commissioner DeBone, how much actual authority we have, but the boards say that a board such as ours can do that. But there are a lot of communities out there. There's a sub forum facilitated by Pacific Source that has about 30 to 40 providers specific to this that occurs every month. There's some things we can explore that I could probably bring back next month for us to decide, but we could either do it ourselves or delegate it is what we need to ultimately decide based on that understanding of the ORs and the recommended secondary audit finding, given our role. And that's kind of what I'm going to have for homework for next time. If I could sort of table it, come back and we can vote whether or not we want to like create something or delegate it. So we just have the right information for everyone. Because this kind of came up there and they had deadlines also with this audit in terms of like when they had to have a response and in terms of like we came up with this definition of lived experience in between meetings after the input from last time was because of they required a response deadline. Just so you guys know that for the transparency side. But yeah, I'll have more on that next time to help clarify. The lived experience one was definitely the more priority one that we can actionably work on and impacts us immediately, like right now.
Could you, start at the beginning? What's the topic? So he said, we'll study and maybe
Something
bring
with
back.
these
But
speakers.
I'm gonna let him do that. Can you-
Yeah, so it's
Drug
sorry.
use tracking or delegation.
drug use.
Yeah, so it's there's a drug use planning commission or committee, and it's kind of nebulous, sort of OIR language. Let me pull that up. Again,
Multiple times for this speaker issue.
Yeah, oh, you have.
So yeah, you're a little scratchy in the room here.
It's not, it's
So-
the speaker, Lee.
yeah, sorry about that. It's
But it's
the
not-
laptop
My
setup.
understanding is it's not as high of an urgency item as the lived experience in satisfying that piece of the audit. And so I think what, Lee, if I understand that you'd like to come back at the April meeting and kind of update us a little bit better, and it might be a better time because you're coming across really scratchy over the speakers here. So it's a little hard to understand. And then Commissioner DeBonne, if we need to get you some more information.
Well, just for clarity, so you, stepping back a little bit here, you said, board members, 51% lived experience. And now is this along that same path, but it's in the drug use world?
No.
Yeah, so that's why I'm trying to understand what the topic is.
No, it's the auditor's requirement, but it has something to do with completely different. It's a task that, as I understand, that the regulations put upon us, but allow us to delegate that as well. And so probably this group, we may make a recommendation that we're not equipped to be doing that tracking as a board. And so we will likely try to delegate it, but it's something that's new to all of us. In fact, the audit, I think, brought up some things. Dana, maybe you can help here.
Well, yeah, so even definitions.
As much, but Amber.
Oh, Amber's got.
Part is not sounding familiar to me.
Yeah.
And the first piece I
So I heard drug use and we need to know something, but what is this? I don't
I
understand.
think we need to get more information out to the whole board about what this ask is in the second piece. I'm aware of the first piece, that is a federal requirement for our CCBHC audit, is that we are able to identify that 51% of members have lived experience.
At least 51.
At least 51%. That due date is actually March 31st. So
I have the survey, we were just gonna discuss it here and then I'll send it out, and then I believe, are we adding that to the application as well?
Yeah, so when we are recruiting new members, we're going to add a question about that on the application to join our board. Like, do you have any lived experience? And again, it's just a yes, no. We don't have to be intrusive or invade anybody's privacy. But that one was due on, and she said March 31st. This next piece is not related to that, but it's another piece from, is it from the CCHB audit?
Holly might be able to speak to it.
Holly will know.
Good timing.
Yeah, so I'm just trying to understand
the
the
second
meaning
part,
of what we're talking about.
the second part I'm not totally familiar with. I'm not quite tracking with the request either. I'm sorry.
Unless Holly has something to say about it, I guess the point is that we're gonna probably address this in April when we have a little bit more information, but we're talking about the audit requirement for drug use tracking or delegation. And we explained it, but the audio is a little scratchy and it's a little hard to understand that. So
And I was just backing up to understand what's the ask, what's the definition of what we're doing? As you walk in.
Is that what that is? No, this is, so I'm.
I put it in the chat.
Okay, so,
Okay, it's in the chat.
There's a requirement, yes, this is.
And Holly, correct me if I got it wrong.
So it's not a CCBHC requirement.
Okay.
But I'm not totally familiar with this ask.
So I can tell you, I know what we're talking about now.
Yeah, so,
Okay,
because I'm like, I don't know what they're talking about.
This actually came up as a part of our contract negotiations with the state in that we are apparently have always been required to have a board similar to this one. It's a local alcohol and drug planning. Planning. And so it's a LA, local alcohol and drug planning. And it's a advising body, much like this one, that will advise on substance use disorder treatment and a vision for how the organization should address substance use within behavioral health. And so my thought last time when we were here was, I just became aware that this was a requirement. I think it had been part of this board at one time years ago. And so my question to Lee when we met was really, should this board have a dual designation, be the Behavioral Health Advisory Board and the local alcohol and drug planning body that could advise on both things? Or is there another body that makes more sense, which there's several groups around that kind of focus more specifically on substance use. And so it's really just a designation. It wouldn't necessarily change anything this board does other than we would have a focus on substance use, maybe more heavily than we currently do. We talk about it, but we don't have, specific agenda items on it necessarily. So that's what the topic is. And the OERs, of course, do not give any guidance around what you're supposed to do. Oh, go ahead.
So do we have a body in our community that serves in that capacity? Or they may, but they're not so named?
Yeah, Lee, that was what Lee had some suggestions around who else might be.
This came up in Yamhill.
Yeah, let's see if he's putting it in the chat. Let's see.
and we're getting a bit behind on our agenda. And so unless there's any, we can provide a better explanation for you at the April meeting, if that's all right with everybody. It's, but basically it's whether we subsume that role as BHAB, or if there's another body out there that's more appropriate to satisfy that OAR and that requirement.
And I would just throw out too, if that one also requires lived experience, that's gonna be different. You're gonna have different members with different, so I would just keep that in mind.
I'll have way more information at the next meeting and I'll have it more prepared.
Okay. All right, and then next up is I had the pleasure of meeting with Commissioner DeBonne last week to kind of talk about process and priorities, just because he's now the new, I don't know, liaison, that's not the right word, but.
I heard there was lunch, so I said I.
Yeah, there's lunch.
Each other a little.
Yeah, exactly. And so he'll be our liaison instead of Patty moving forward. And what I learned from meeting with him is that during the legislative session, the commission has established a set of legislative priorities that they rank on a scale of 1, 2, and 3. 1 being like, this is urgent, we need to get some attention to it now. 2 being, we support it, but we've got a little bit of time, or it's not, it's important, but it's not on fire. And then 3 is that the commission is just kind of watching the status of that.
So if it's a number 3 priority, we might say we support it or oppose it, or we're gonna watch, but not really do much. If it's a number 2 priority, we're pretty interested. If we're so inclined, maybe we'll write a letter or do something. Number 1 means full speed ahead with resources, lobbying efforts, and sending somebody to Stingham. And she's full speed ahead on a couple items right now.
And the commission.
But we could talk about legislative positions here in support of the commission's, approval, and then I'll be in Salem next Friday, and I've been about 4 times already this year. Yeah.
You guys are driving an awful lot, and so it is published on the commissioner's website. It was a little challenging to find because you had to go into the meeting for the legislative update that they hold every Friday morning, and then go into the board or the commissioner's packets in there to find it. But it's a nice list when you get there, to show the different departments or the different areas of county government. And so there's a section just on behavioral health. And so I counted five bills that have been introduced into the legislature so far. And I see that there are, of those, there's 4 that are priority 1. There's 2 that are priority 2. The one, the issue that I wanted to ask about is, what is the role of BHAB in helping? Because we hear from Holly and then we hear from the commission, and for the most part, I think the interests are aligned there, but how do we kind of prioritize our work and decide how we do it? And what I heard from you, Commissioner DeBonne, is that as long as the work is reflected on the legislative priorities on this list, then we can work with Holly to kind of put a plan of action for our own advocacy.
But new bills can be proposed to be added to that list every week. It's not a static list in any sense. It's basically what's coming in from the whole organization. What have we heard about? What are the commissioner's priorities? But this is the body that can provide content to us to say, oh, this matters to us. If this passes, it'll be good or bad. If it doesn't, if we want to oppose it, whatever the situation is. And think about this for the public members of this body. You could be side by side with me testifying in front of the legislature. We can do it remotely or go down and sit in front of a committee. And that's where the rubber hits the road. I mean, if a public member is hot on a topic and you come and sit side by side with me and we're in front of a committee, we can use our words and look people eye to eye and say, this really matters to us, or this is really going to crush our world, because it goes different ways. Or side by side with Holly.
Can I clarify something? I just, something you said, or I can't remember. We're not saying that what we choose to do has to be 100% in agreement, because we're independent.
Exactly.
Okay, I just wanted to make sure.
Any individual can do anything.
You want me involved.
Yeah, so the
Got it.
official position of the county.
Got it.
Because as individual commissioners, sometimes we go, there's 3 of us, right? And we go 3 different ways sometimes.
Oh, I know.
And we've seen that. But,
Yeah.
but then if I'm passionate on it, I'm like, those other 2, I need to get down there, So I have the authority to do that as an elected individual and representing the county countywide. But no, there's no limits on you personally,
Okay.
no.
Got it.
But when
Just
you
wanted
say
to
I'm
make
here
sure.
on
I just
behalf,
heard- Yeah.
if you sat in front of them and said, I'm here on behalf of Deschutes County, of Behavioral Health Advisory Board member, and this is what we're doing, that's when you're taking on the role
Oh,
of
wait.
the umbrella of sitting here.
I want to clarify that. That's what I was trying
Yeah.
to say. I thought the Behavioral Health Advisory Board was an independent of the commissioners and the counties. Is that not?
I think, Commissioner, and correct me if I'm wrong though, I think this board can take any positions that they want to take on anything. If they want me to support or help or do anything along the line, then it needs to be aligned with the priority.
So, yeah,
That's
so
what
I
I
mean,
was thinking. Yeah.
Staff
as I
have
say, I mean,
Yeah, yeah.
if this board says we're going left and the 3 elected countywide commissioners say, no, we're going right, we just acknowledge that, man, we're not seeing it the same. Because we do that. We do it all the time.
Yeah, and the purpose in our bylaws, when we have questions about what our scope is, I always come back to the bylaws for the organization. And it says that we serve as a bridge of communication and advocacy between our community and the Board of County Commissioners to improve the quality of current and future behavioral health services. So I see it as kind of a two-way street. We're independent enough that I think that we can bring stuff up and say, hey, Commissioner DeBonne, this is important to us. I don't know if this is on the radar of the commission.
And that's the starting point.
But that's kind of the advisory piece when we go that direction. But I also think that we're kind of stepping into some new territory with this board now, trying to shake some things up and be a little bit more productive. And so I think it is best as our first foray into advocacy, since at least I've been involved, that we want to make sure that we are in alignment, and we actually do have a workforce bill that Holly will talk to us about that is listed as a priority 1 on the county commissioner's legislative priorities. And so we're in alignment there, and that's an easy one for us to kind of put our toes in the water. Because I do think that this group is going to be evolving in how we function and what we do. But I think that's a two-way street that,
Yes, because you acknowledge differences, but we're still here, it's just like a family, we have to work together, so.
And for the most part, I mean, my experience in these settings has been the bills that are a priority for Association of Oregon Community Mental Health Programs and for us, the commissioners have almost always supported that as well, because they know, usually something that's really important to us is going to affect us financially. It's affecting our workforce. It's affecting the clients we serve. And so they tend to really hear our expertise on the matter. And we've been aligned so far.
And remember, counties represent everybody inside and outside of a city, so we represent the whole population. There's 36 counties. So when AOC and the AOC and MHP, take a position, a professional, informed position, I'm not the expert in that, because we're talking to the legislature, which represents everybody inside and outside the city also. So it's just, and usually it boils down to, well, here's an unfunded mandate, go do this, even though you don't have money for it, right? It just boils down to money usually.
And there's a couple of instances where we have legislation that maybe one part of our county departments are opposed to, and behavioral health might be supportive of, and so you get this sort of tension between departments, and not tension because we still get along, but we just disagree on the bill, and so then the commissioners sort of either weigh in or stay neutral, or we just sort of
get more informed
on it, and pick one, so those things can happen. But for the most part, behavioral health, strictly behavioral health bills where they don't overlap with other departments, we get lots of support.
But communication's the key.
Yeah.
So today is the day that if a bill isn't scheduled for a hearing, it'll just drop. So remember, there's been 2,000 and 3,000 bills for this long session. There's 5,000 this year. And after today, if it's not scheduled, next Monday, there'll be a whole bunch of stuff that just disappears. But then it gets more acute on the things that are alive. And there's big issues and big funding packages that come together. Then there's also individual standalone bills that may or may not be seeing the light of day after next week. So it's a wild ride.
Yeah, it is. All right, and so moving on, we are going to do committee reports, and Cameron was going to present on, Peter, were you part of the interview team of the?
No, I cannot operate my iPhone apparently.
Oh, no.
And I so didn't bother to actually show up.
So I thought Cameron would be here today to kind of present this, but I know that she and I can't remember who else was somebody else on that interview? I thought it was somebody else. Anyway, they interviewed the St. Charles gal, Molly, what's her last name?
Cameron, Peter, and Stephanie.
Okay. So unfortunately, I think what they would do is they would be recommending to BHAB that we vote to recommend to the county commission that we bring this member on. I'm not sure what to do here since neither.
So we like Molly, and we did not have her CV at the last I saw it. So I don't think we can vote yet.
Well, I don't know that there's a rule saying that we have to have a CV or we have to have an application. I haven't seen that anywhere. I don't know if anybody has more information. The issue, what he's talking about is that prior to now, we had a really complex application. If you guys all remember the applications you filled out. Yeah, it was for county employees that the HR, and which is a whole different deal. And so we got confirmation that we did not have to use that complex of an application for candidates that want to be on the board. And so I created that application for the transitional youth person that's kind of fizzled out at this point, but it was a simpler application. And so there was just a little bit of miscommunication about whether I thought they were going to use that, but we're new. We're doing new things. And so I think maybe we will wait until next month when Cameron can present and we'll have time to get her application.
Do you need Molly to do it? Anybody reach out to Molly? I talk to Molly every other day.
Maybe just let her know it's really because Cameron's not here, and I think I was communicating with Cameron about the application, and I'm like, just do that simplified, youth form if you want, or do your own form, whatever you want, or the application. Just have her do it as almost as a pro forma thing. Again, I'm not aware that we have to do that. I mean, I don't think there's any law that says that, but it's good practice.
So between now and the next meeting, could we all get her application if she did one? That way we will have been able to read ahead of time and then we can vote on it right away. It seems like we don't want to prolong it any further.
Yeah.
And then we can invite her
I've
to
done that
the
on
next
lots of
meeting.
things.
If
Yeah.
we have.
So Dana?
Can I ask a question? So back to the 51% of our board needs to be with lived experience. And I think we're really, are we?
Well, I don't know.
I don't think we are. I don't think we're close.
Oh,
Based on a conversation maybe that I had with Roger a while ago, and he was gonna get that information for us, but my concern is, are we bringing somebody on and it's not my business or whatever if this Molly gal has lived experience or not, but if we bring her on and we're already skewed, then, you know, we need to figure out
Yeah.
that
The
piece.
problem is that our knowledge of the 51% came after the whole interview process
Oh, okay.
with Molly started.
Okay.
That's
Well down the road.
the
Okay.
challenge. And so this audit requirement of 51%, I think is new to us. I don't
and my suspicion is you will be surprised.
Yeah.
Oh, really?
And that's why, and to be quite honest,
Broad definition.
yeah, we made the definition of lived experience as broad
Little
as we could.
broader.
You
Okay,
know,
good.
If you've had any behavioral health challenges or have a family member or a household member that has lived experience that has had a significant impact, that is our definition.
Oh, good, okay,
I will qualify
okay.
under that definition. Yeah, most people,
People will call.
I don't think we want to water it down too much because there is an importance to having voices who have lived through some really crappy stuff. I think that is key. I do think
And
the
then-
definition's good. I just think we should think about it when we say it, like,
Yeah.
my dog takes anxiety medication.
Well,
Or, you know,
exactly.
I mean, but for those of people who have been in deep, I think it's really important that we have those voices. That's all.
Shouldn't be diminished.
Yes. Thank you.
Well, and getting somebody engaged may be the trick. It always is, right? So, yeah, let's bring whoever we can.
I've been working on.
Okay, good.
yeah.
We'll have that survey out really soon, so we'll
We'll know pretty quick,
what
yeah.
percentages of identified,
And the other thing too is that Molly comes to us from St. Charles, which I think is a really important voice on this community. So there's other reasons that we might want her here. And so if we're not reaching that balance, we haven't, I think we go up to 13 members, we still have room to bring on other people too. So, and I don't know, that we have a member or two that I haven't seen a lot at these meetings in recent months. And so I'll have to find out if they want to continue, and that'll be playing into the mix. But I don't know that I want to hold up on inviting Molly because she's already gone through the process. And yeah,
Well,
so
I'm a little lost on mine. So we've been talking about her a lot. So did she get interviewed and does she have an application?
she has not done an application.
She has been interviewed.
She
She
has
hasn't been interviewed, and the interview team, were you weren't on the interview.
That's, you're talking
Stephanie
through
and-
technologically.
Yeah.
Stephanie and Cameron.
Yeah, 'cause
Stephanie,
we
yeah,
know
okay.
Molly.
I couldn't
Molly
remember.
would be here the next day if we needed her. So, we kind of, and I may have missed it, who's doing the application for her?
I'm working with Cameron on that.
Okay.
Yeah,
okay.
yeah. It's just, we're just in a period of transition and revising some stuff.
I
and so
know,
it's
I
got-
know.
So we will have Molly do an application. Holly if you talk to her, could you please invite her to the April meeting? And I think we will take a vote on her at that time, and by then she will have filled out the application. I'll work with Cameron on that piece of it. And then Cameron and Peter and Stephanie can make the formal recommendation to our board. We can vote on it in April and she'll be a member. But, I showed up to these meetings for probably 3, 4, or 5 months without interviewing. And so we're fine. I think we're on track on this. Linda, you had your hand up?
Yes, just for what it's worth, because I was brought on last fall and I was told to, and I don't know if this is helpful, but from the receiving end, I went to the county website, looked at the application and went, oh my gosh, this is overwhelming and blah, blah, blah. So I went back to Roger and he said, don't worry about it. Fill out what you can, write me a letter. And then you all did your thing behind the scenes and then you brought me on. So my thought would be the good judgment that you're using is probably okay. I don't see that there's anything prohibiting it and that we would have enough freedom to use good judgment until you want to get more formal. That's just an opinion.
I'd ask Molly just to submit a CV and
Yeah.
and I can invite her to the April meeting, and then while you work on the application process, that way you're not rushed to like, you know. It's up to you all.
I've served on a number of boards, public and nonprofit, and sometimes they use an application, sometimes they don't. I have looked at the OARs for our group, and I don't see any issues. I don't see any mandates that we have to have a formal application process. I think we want to as best practice.
Yes.
And we're in the
To
process.
identify too, the lived experience, I think that's a big piece of it, because the CV is not gonna tell me.
Yeah,
So
exactly.
give me a lot of information, but yeah. I'm curious if we don't have the 51% by, I think you said it was March 30th.
No, that is to tell, the March 31st date wasn't to have the information, it was
have a process.
to have a process.
We have
And so that's what has been established, is that process to send out a survey for us to
Okay, that's all.
Yeah, so.
All right, just wanted to make sure that's what we were talking about. Yep.
So do we still need, I'm sorry, maybe you didn't call. Do we still need to do some research and digging around on what people consider lived experiences? Do you feel like that's kind of already done? Because I was gonna say, I'd be willing
Yeah,
to
we
get
haven't done,
busy and look on the internet and look at a bunch of definitions. That's a little bitty task I could do if it's.
Yeah,
something to be
Linda, I
done.
don't think we need to do that. I think we've already
Okay.
adopted the definition that will satisfy the CCBHC audit. And it's a broad enough definition that a lot of people might qualify. I don't think we need to fine tune that more unless our auditor tells us that we need to go further. So I think we'll stick with what we've got right now. And if we learn that we need to go a little bit more into depth about what qualifies, then we can adjust that at this time. But again, this is a self-report. And so, I mean, I guess we could tell people this is what it means and refine it. But I really, for purposes of right now, to meet the auditor deadline, let's stick with the definition that we currently have. And then if somebody wants to call one of us to say, hey, does this qualify, then we can kind of help them through that problem-solving process. But thank you for offering to do that. I just don't want to do unnecessary work that we don't need at this time.
Totally agree.
Okay. Moving on. So we've got the membership onboarding report, as it were, and we'll revisit that in April. And then outreach, Julie.
I already actually weaved it in. So I went to the Lighthouse and it's 100 seats and, you know, there's nothing really during the day. They can't be in the area where the bunks are, 100 bunks. But they can come back at 6 o'clock and they can be there indefinitely, but they have to be consecutive nights. If they leave and disappear for 2 days, they don't automatically get back in. They have to get on a waiting list. And she said that there's a waiting list every night and people do get turned away. And 3 meals a day will eventually, they'll be there. And then what was the last thing? Pets are allowed. It's co-ed. And I think that was it. You know, they're coming along. They've got some good things going there, showers and all that kind of stuff.
And
So
throw out Mosaic visits there with our mobile clinic to provide healthcare services too. So, and we're working on increasing our supports for people experiencing homelessness. But I know that we do have Lighthouse on our regular.
They've been excellent to the jail for warm handoffs. We use them weekly. So we go over there. I've dropped people off over there.
oh, that's what I was gonna say. And I guess if it drops below 25 degrees, they can take on an additional 35 people with mats and stuff. That's just a temporary thing. So they can actually, absorb a few more people when there's those really cold nights as well. So they seem to have a pretty good
Very
system in
generous,
place.
hardworking, very generous folks out there.
Yeah.
Hardworking.
Okay, moving on. We have a quick agenda item for upcoming events that we're just gonna have this as a monthly agenda item. So if you have events that you want the board to know about, now's your chance. Julie, do you have some things for NAMI?
NAMI Walk is May 18th. It's a Sunday, Pioneer Park. Consider jumping on the website and starting a team or donating or coming to the event. It's free. We are doubling in size. I think we're gonna maybe hit 350 to 400 people this year. We have double the teams already and we're already higher on individual donations and team donations than we were at this time last year. So we're getting some momentum. So
So Julie's doing an amazing job kickstarting NAMI's fundraising efforts. And so she's doing a lot of like silent auction type items. And if you guys have any ins with any businesses that would maybe donate a good auction item, I bet you'd like to hear about it.
well, yeah, I'll take anything at all. And I'll do something with it. We'll make some money.
What was the date?
May 18th, it's a Sunday in Pioneer Park.
I will throw out that May 7th, Mosaic is having their second annual luncheon, and hopefully you all know Mosaic's a nonprofit. And this is just an opportunity for us. This is not my department. I don't do this stuff, but I am there at it. But we usually have a video, a very heart-wrenching video. Tony, I believe you were there last year. That was a tearjerker. I had a hard time with that one. We'll have another video this year just about, our patients and who we're serving, and it's just a luncheon, free to go. Obviously, we're asking people for donations, but it's we have it up on our website. So if you are interested, Peter was there last year too. Did you cry? I cried. I cried at that video.
There was tissues on the table
It
just for
was
that
a
purpose.
hard one. That was a great one. I don't know if we can beat it this year, but I think we are doing it on, as far as I know, the video is on our street medicine program, which is new,
That's such a cool program.
upcoming,
Yeah.
that we're really working hard to fund and get going. So.
You. All right, Holly, sorry.
I'll be quick.
I was looking at the bill and I'm like, thankfully, it's a very short bill.
It is a bill. This is our workforce bill. It's going up for a hearing on Tuesday. So if the board wanted to submit written testimony, really the bill is asking for $20 million towards behavioral health workforce for things like tuition assistance, for things like housing stipends, child care stipends, just anything to help keep the workforce in the workforce and things that prevent them from being pulled away from the workforce and leaving to go to private practice. And there's also $5 million attached to a program called United We Heal, which is a partnership with AFSCME. So this is really a collaborative workforce bill between AFSCME, the CMHPs, and that is for an apprenticeship program that United We Heal is involved in, and we're having some conversations internally about whether we participate in that, but it's complicated. But really what this bill would do for us, would help. I mean, we have a lot of these programs already in place that were built off previous workforce investments that came our way. So it just got a scholarship program approved at the board yesterday. It would help me continue those things because we're working off a limited bucket of money right now. And when those funds end, we don't have any other resources to contribute to things like the stipends and the tuition programs that we're doing now. So I think if there was a letter to be written, it would really be around, the publicly funded behavioral health system has been hit incredibly hard with the workforce crisis. And we need to do everything we can to keep folks in this system because there's not a lot, they have other options that are way less difficult. And so we need to incentivize this as best we can with things like these options. So
What's the number of the bill?
it is House Bill 2024.
And this is a priority one.
Yes.
For the Board of the Commissioners. And so I think your ask is that we as a group approve a letter of advocacy or letter of support for this bill. And if anybody wants to testify, I don't know the process of signing up if it's too late or.
I think I sent you on, there's a link.
that
It's really easy to register to testify. It says register to testify, you click on it, and then you can either do it virtual, you can submit written, or you can go in person. And so you have all those options available to you. I don't think for this one is not a controversial bill. There is a lot of support for this bill. So I think a letter is perfectly sufficient from this board if you all wanted to do something like that.
So you think a letter of support versus written testimony? Do you have?
It's the same thing. Yeah. And the link has the portal for where you can submit the written testimony.
I see them as two different things. One's unofficial letterhead and one is just through an email.
Yeah, there's templates and we can figure out the logistics of doing that. And so the ask here is for a letter of support or written testimony from BHAB that we would sign. We'll have to get into those details, but
What year did the sheltered workshops, Ability and Opportunity
Linda?
Foundation close in Oregon?
Liz, can you, okay. Thanks.
When do you need the letter by?
Well, the test, I think it needs to be submitted fairly soon. I mean, we're on a tight time. In fact, I don't know if it's passed already for you to be able to submit it. That'll be something we'll look at when we submit. But if you can submit right up into the day, I think.
You would like to put a written testimony, you put it in 48 hours after the hearing.
Okay. Oh, you can go after. Oh, okay, perfect. Then we have time.
So I
because
think
it's
we're
Tuesday.
good.
Confirm that, but I think that's the way it is.
Holly, do you have some text you could share that we could use as template to kind of, then put the kind of BHAP flavor to, or?
We can support that, yes, I think.
We have the one pager that I sent you. I still
Okay.
have it.
So we have.
There's language in there about what this bill does. I think you could take some pieces of that and say what you support. It does not need to be long. You just want to say you support it and that, who you are as a behavioral health advisory board and why it matters to our
My
community.
impression is that the volume is just as important as the content.
Having a nice letterhead,
Yes.
having the names on the letterhead, having, the chair sign it, that's the value right there, it's taking a position. So,
And how many you
lots
get
of words.
is like,
Yeah.
is really where that kind of like, oh, okay, there's a lot of
Do
support.
we
for this.
have BHAP letterhead or is it just behavioral health letterhead?
Just behavioral health.
Okay, which is,
And this is a priority one, so we could use the
In my
county.
experience, for like in a group like this, is you just put all the active members on a list down kind of the left side under the county logo and document it as such, Behavioral Health Advisory Committee. So you kind of create a logo out of the county's letterhead or
okay.
a format.
So we'll kind of work on those little details on how to do it. We have an advocacy committee, on our agenda. It says that it is Danielle and Lee, but I also have, Stephanie's on it as well. And she's not here. But what I'd like to do is put this to a vote. If anybody has a motion to have this is our first letter of support. And then we'll ask the advocacy committee I'm happy to support too, because I love to write, is kind of what I do. And we'll get her done as quickly as possible. And so does anybody have a motion or?
I move that we support doing this letter for this particular.
I just want to say I have a hard time voting on it without having read the bill. I bet it's amazing and I'm 100, but I'm one of those people who reads things before I.
It's really short. It's really short.
It's a short one.
It's like, I mean,
Well, right now, the way it is, it just says they want the Oregon Health Authority to study the work for, it was a placeholder bill that they're waiting on the amendments to still come through because there was a lot of coordination with AFSCME. So at the end of the day, the one pager I provided you is what the bill is going to be focusing on the 20 million. Right now, the bill is not going to tell you a whole lot. This is the first hearing probably of several.
yeah, I don't know if you guys can see it, but that's the bill. And most bills are not this short. And it just says that the Oregon business, no, I'm sorry, that's the wrong.
The amendments are supposed to come out today. That's where I was before.
Which number did you say it was?
House Bill 2024. And amendments are coming out today. If it's longer than that now, then the amendments have come out. So, but if you look, probably by Monday, the bill should have the amendments there posted. That will make the bill much longer and more detailed.
And the legislature recycles the bill numbers, so you got to make sure that you say 2025 legislative session or legislature to find it. But it just requires the Oregon Health Authority to study the behavioral health workforce and submit findings to the relevant legislative committees by September 15th, 2026.
So whenever you see a bill that says require the health authority to study, it's what they call a placeholder bill while they're working on the details.
I did not know that.
Yeah, I learned that this year.
So if you guys don't want to, we have it as support from the county commissioners, and we've had this request by Holly. We are lacking some details about what is all going to be in there. So I don't know your comfort level about approving this, but we need to do it before our April meeting if we are going to do it. So
one other thought, this is going to be a financial ask in the end, right? 20 million. Yeah. It's going to go in a pool of all kinds of asks. So all of a sudden, Ways and Means will get in there and just start chugging through all these asks because there's going to have to be a line in there somewhere. I don't know if you have any other insight into would it be funded? Even if it comes out of committee and said, this is the number one priority and 20 million is the most important thing, it may fall below a line to get funded in the end anyways. But
we feel it has legs just because it was in the governor's budget too. And so I think whether it gets 20 million or not, who knows? Like with any of our asks right now, we assume it's going to be less than what we're asking for. But we feel like workforce is of top priority across, I mean, everybody's pretty aware of the workforce issues. So I feel like if anything's gonna get funded, this will be funded at some level.
Well, and it's everybody's ask is important too.
It's
Just gonna
true.
be interesting, to see what
But
else
with
shakes out.
behavioral health being on the
Yeah.
governor's top list.
And by and due to the nature of the legislative session, these bills change over time before they get to the end result. And so it does put us in a position, if we vote in March to send a letter of support, we're supporting what we know about it now, but it could change. And so it's going to be a moving target on pretty much any legislation that we are going to vote on. And so keep that in mind as well.
Yeah, with this one, Association of Oregon Community Mental Health Programs, we drafted this one. So any change, and it's being sponsored by, I think, Rep. Nose and other. And so any changes that would happen to it would have to have the support of AOC and HP and the people working on this bill. So I think you can feel good that we wouldn't allow it. We would let it die before we got changes in it that we didn't support.
Hey, Holly, there's not much in this bill, so a little bit more information from you would be helpful.
Yeah, I don't have any more information right now other than what was in the one pager around that this is going to go towards tuition assistance. It's going to go towards housing stipends, child care stipends, and the United We Heal program. And really, we're trying to make the funding as flexible as possible. We're trying not to tie it to specific, really concrete specific things because every community is different in terms of what their workforce needs are. And so we want flexibility to apply these dollars to do whatever it takes in our local communities to improve our workforce situation. So you're probably not going to get an enormous amount of specificity in the bill for a reason.
So I think we had a motion though, right? And we haven't seconded it.
I have not heard a second.
I would
Julie,
second.
Julie moved to do a letter of support for House Bill 2024. Danielle has a second. Do we have any further discussion on this?
The only thing is, before our group, I'd like to, before our group starts stepping in that to make sure that our voice is really important. We just start jumping in and approving. I don't know if that's a good access to our time. The ones that are really important, that's what I'd like to see. I don't know if this is that important because I have no.
This is the top priority for us. This is this and the cost study bill, which is the other big bill. We're asking for $64 million to fund civil commitment aid and assist in crisis. These are our top two bills.
It just seems like a lot of money to me, so I want to be real careful.
So it seems to me like, just having sat on this bill for a while, or on this board for a while, my purpose of being here is to improve behavioral health access and programs to Deschutes County residents. And from what I hear all the time is half of the problems that we come up against are that we don't have enough people. And we're hearing that from every corner of behavioral health. Nobody has enough behavioral health people, and they don't have enough because they're not trained appropriately or we're not paying them enough or whatever. So I kind of feel like finally this board is going to do something and have our voice heard. And if Holly's telling me it's her priority for the Deschutes County Behavioral Health and it's a priority for the commissioners and it's a number one priority, this would be the perfect opportunity to jump in with both feet. Because if it's going to get more, if we're going to attract more people to behavioral health to take care of our residents, then that's what we're here for, it seems like to me. So I'm all in. I would vote on it in a heartbeat. But
just so that you know, Lee and I have had a lot of discussions. We're still new in our roles. We're still trying to find our way, and we're still trying to brainstorm ways to make this group more effective. But one of our plans, and it's hazy in how we're going to do it, but it's an active conversation, is bringing to you guys a process by which we kind of identify on maybe an annual basis what our top 2 or 3 priorities are in consultation with the commissioners and with Holly and their priorities. But we are an independent group, and so maybe some issues are not as important to us based on our perspective. And so we're going to have a mechanism to kind of figure that out, but that's probably for the April meeting. And so we're not just going to be picking up things. This one, we know it's important. We know it's priority 1. We know Holly wants us to do that. It's an easy one that I think everybody can get behind. And it's also our first foray into doing some advocacy. And so it's a good putting our big toe in the water for right now with a fairly low ask. And so that's why I would recommend that we consider doing this, but just know that we're trying to be thoughtful about how do we organize our priorities here in conjunction with the commission and with Holly and hearing your voices too. So we'll bring something to you probably in the April meeting. We've got some ideas. So we have a motion on the table to do a letter of support for House Bill 2024, and Danielle, you seconded. Any further conversation? All right, all those in favor, say aye.
Aye.
All those opposed? Any abstentions? Motion carries. All right.
Appreciate it.
Yeah. So Danielle, since you and Stephanie and Lee are on the advocacy committee, Lee and I will loop back with you guys and we'll coordinate what this looks like.
I'm happy to review anything, but
Yeah.
whatever you need.
I mean, I write letters of support all day long and testimony, so this isn't
Perfect.
new. But I would love the one pager to have some
Yeah, and-
information, so.
I just sent it to the group, so it should be fine.
Okay. And then I think it sounds like I have to sign it.
I think it would make sense to list the Behavioral Health Advisory Board members and then have you sign as the chair, and that